call center is the nerve center of how everything happens. I mean, everything comes through there. So they do a great job for us and makes all of our programs very successful. So Donna, welcome.
Well, thank you. He's already introduced me, but I'm Donna. I'm no longer the call center manager, but that is my area of specialty, so I would like to focus today on how we've used interactive video and how that role is quickly expanding in the use of the call center. First of all, we've talked a little bit about Angels, but I just want, this is a little difficult to use. Let's see if I can figure it out. There we go. So I just want to talk a little bit about what Angels is, in case you guys have missed that so far. So it is an acronym that stands for Antenatal Neonatal Guidelines Education Learning Systems. So it was the first of its kind to link 3 state agencies, the University of Arkansas for Medical Sciences, the Department of Human Services, and the Department of Health. And that was necessary because there was a crisis in women's health because, as Dr. Hitt was talking about, you know, we have an impoverished state, medically underserved, and this was causing low birth weight babies and just general poor health for the women of Arkansas. So Angels has developed a clinical telemedicine system with 49 sites currently, and it's outfitted to deliver a comprehensive range of telemedicine services to this population we just discussed. This is a map of where our Angel sites are currently. So you see that they're well distributed throughout the state. So I would like to, I want to show you this short clip of this video that just really explains well what Angels does. Well, let me go back. I'm going to do what Dr. Hitt did too, because this is not easy. Okay, very sensitive. Hopefully our audio will work with this. Okay, so that kind of gives you, if you didn't already know, kind of an overview of how we use telemedicine in Angels. So this is what our telemedicine model looks like. We offer community-based needs services by providing education and training for providers. We have a centralized technical support and scheduling with the 24/7 nurse triage call center, and we're going to talk in depth about that. A telemedicine network and infrastructure, evaluation and research of our program is ongoing, and case coordination, evidence-based guidelines and protocols. So first of all, since I'm not going to go in depth about all those other things, I do want to direct you to our website, angels.uams.edu, and there you can see the guidelines that we have both for pregnancy. We have over 100 guidelines for pregnancy, and also I think over 50. Don't quote me on the on the neo ones, but a lot of them for neos and peds. So also there are scientific posters that are on the site, and there's specific things for healthcare providers for education, and also handouts for patients. So it's just, there's a wealth of information. Also, you can find, we have teleconferences. Dr. Hitt was talking about one of them that is our, our mainstay, our Thursday morning high-risk OB teleconference, where OB providers from around the state get together and they talk about a case is presented of a difficult case that we've had there at UAMS, and then they discuss it. How well did it go? How could it have gone better? And then they present a guideline that goes along with that, and that's discussed. And if it needs to be revised, that's revised. So it's not just UAMS dictating care, but it's collaborative, and it's using other physicians around the state. So all those guidelines are on there too, as well as the conferences that are available, because there's a list of different ones. So, of course, my favorite topic in Angels is the Angels Call Center, and it is what supports the Angels program and the Center for Distance Health. So you're going to hear the Center for Distance Health. That's our big umbrella that covers other things that we do outside of OB, because we're innovative in telemedicine, so we've moved outside of OB with that. So in comparing just a traditional call center, you have a nurse, a phone, a computer with triage software on it. That's your standard. That's what you see across the country. There's a disadvantage that this is completely subjective data. It really hinges on how well a patient delivers information, how well that nurse can pull information from the patient. But when you have the addition of interactive video to the call center, now you've become a lot more objective. The nurse is able to gather a lot more information with her eyes that she wouldn't have been able to just over the phone. So I'd like to tell you about how we introduced interactive video into the call center. It started back in 2006 when one of our earliest projects is when we started doing triage with one of our local prisons that they took in. There are pregnant women in prison, if you didn't know that, but they moved them all to a central unit and that had an infirmary. So there's nurses there 24/7, but these nurses are not highly skilled. They're usually LPNs, and no offense to LPNs, but they're more skill-based than triage-based or critical thinkers, and because that's not how they're trained. Not that they're not capable. Let me just give a disclaimer there. Sorry about that. So LPNs, but also their turnover rate was very high, because I'm assuming that's a high-stress environment to work in. So keeping people trained to triage their patients was difficult. So having interactive video there was helpful to the nursing staff that's there, so they can connect with our call center if they had an inmate come in that had complaints. And then the nurse would call us, and we would make the connection between us and the infirmary, and we'd be able to triage the patient there. So the whole goal was be able to provide better care for these inmates. So we'd be able to help the staff there to be able to provide the care that they're not specialists in OB, so they have a fetal monitor there, for instance, but they may not know how to put the fetal monitor on the patient correctly. So we can visualize that, and we could help them place the monitor on correctly, make sure they were getting a good strip for us while we triage the patient. So The goal was, it's very expensive to bring these inmates into the hospital just for a check. And a lot of those we were able to avoid by being able to triage them over interactive video. Okay, I think we might have another point on that I'll remember in just a minute. But the main thing with our training early on was that it was basically just train the trainer. So I was the main trainer in the beginning, so I learned how to use the equipment, and then I had super users in the call center that I would train, and they would help one another. And we were making all the video connections, and they were just basic point-to-point connections at this time. And there's a lot of troubleshooting when it comes, everything doesn't always go correctly. So if there was a problem, we would troubleshoot, and we were helping a lot the staff on the other side, again, for the same reasons we discussed before. We would go out and train them how to use it, but they wouldn't stay long, so we would get people that didn't know how to use the remotes or anything. So we were able to talk them through all of that. And then, of course, the clinical documentation of the triage and facilitating whatever the outcome of the consult was. So the nurses that were learning this new technology in the call center, there were some things that came across, and this was really surprising to me, that one of our biggest barriers, the nurses didn't want to use it because they didn't want to see themselves on video. I thought that would be one of the least concerns we'd have, but when I looked on the internet for pictures of call center nurses, this is what I found, and I don't know, but I've got some pretty nurses, but they don't look like supermodels. But most of all, it's our own self-image. We don't like to see ourselves, no matter how good we look on there. We don't like to see ourselves on video. So basically, this just took time, and they just realized that this was something that was going to happen. They were going to have to see themselves in self-view, and then they could take self-view off of there if they wanted to. Video etiquette was another thing that we soon realized that telephone etiquette and video etiquette are not the same thing. So things that you would think that would be very common, common knowledge that people would think were not so common. So we had to point a lot of things out. We had many nurses, looking back, and they would probably be really upset if they knew I was telling these stories on them. But so, maybe self-image was up there, their self-view was up there initially. And then once you make your a few different connections, maybe you're not seeing yourself any longer. You've got a big view of whoever's doing the consult or anything. In their mind, I don't see myself, they don't see me. So, they, at that point, they're muted like they're supposed to be, but maybe at that point they're going to stand up and stretch their legs, or going to get comfortable. We have one nurse, this is all they saw of her probably for, about 20 minutes, so, those kind of, or we had a tech that was in the call center that he'd be talking to the nurse, that he would come up and join them and tell them jokes, they're laughing. Now, they're all muted, but if something serious is going on the other side, and that patient sees people on the video laughing, they're thinking, well, they're not taking my situation very seriously, or they're laughing at me, things like that people, they weren't even considering in the call center. So we had to do a lot of teaching. I'm going to go back one. So the best thing that we found out was having them do self-review, having them look at their recordings, because we recorded all the calls. And because we went on with time with us just telling them, you need to do this, you need to do this, and here's the protocol, you need to follow this. But until they saw themselves and saw what they looked like and the things they were doing, we didn't have to say anything. As soon as they saw it, I can't believe I did that. They could point it out themselves, and it soon changed once we added this self-review into it. So we started adding many different video projects. Telenursery, Dr. Hall is speaking today, I think, about this, but doing virtual rounds of nurseries around the state where they're giving what their census is, whether they can take back transports, just to really help the congestion and the flow. And they also were doing consults. At that point, it's increasing the rapport between these nurseries, and they would also say, oh, and I need to talk to you about that patient you sent me yesterday. And then they would do a consult on that baby afterward in a point-to-point connection. Then we added our telestroke program, Arkansas Saves. You've probably heard that referred to a few times during this conference, and we're going to talk more about that in a few minutes. NICU transports, they started using that. Children's, when they were going to go out and get a baby, we would make connections, and there would be about 6 different connections with that for everybody that was going to be in on the transport to be connected. Mom and baby connections, moms that were separated from their babies either because either one of them were too sick to be together. Usually the mom was in ICU, or we make connections with those so mom could see her baby on video. Baby could hear audio. So promoting bonding when they were separated. Nurse-to-nurse report, where when we were doing our OB transports, if we had a unit in that labor and delivery or the nursery where that patient was coming from, we had the nurses start doing their nurse-to-nurse report over video. We saw a lot. I don't know if anybody has any experience with OB nurses, and I can talk about them since I am one, but they're not always the nicest people. Not I am, but no, they tend to, over the phone, just in general, you're going to say things to someone when you're not seeing them face to face, you're not going to easily be rude to someone face to face as you would be over the phone. So we saw, it was amazing that the transformation we saw by these women seeing each other face to face. Rapport was built, and these are people that they talk to frequently. So, once that started happening, even if it did happen over the phone next time, they know this person. So that is something that has really worked well. And then when the situation that we could have the patient even come in front of the camera and meet the caregivers that were going to receive them, that is something that we've done on occasion. That doesn't work as easily because where they have their telemedicine units aren't usually in an area that it's easy to get the patient to, but we have been able to do that some, and the patients really like that. It makes it, because coming to the big city of Little Rock is scary for them, coming from a rural area, so they really like it when they're able to meet their caregivers. Other things that Children's has used it for, if we have these units in EDs because of the telestroke program we're doing. Well, if they had a peds patient come into that ED that needed a consult, they would use those units to go ahead and hook up with Children's and do a consult with them. And the same thing with their PICU transports. The burn center at Children's is also now using this to look at their patients and decide if they need to come or not. And a lot of those patients may not even need to be transferred, or to give care advice before they come in. So the way that our training worked was, first of all, we noticed early on when we added the telestroke program that we needed a nurse dedicated just to video. So we had a nurse that we pulled out of the call center that was very good at interactive video to focus on our telestroke program and in training just in the nurses and using all the video equipment. Mainly doing that by shadowing. For when new nurses come in, they shadow and they watch it for a while. Then very detailed one-on-one instruction. Having some group class time for maybe our outreach nurses in our stroke program would come in and talk to our nurses and tell them kind of how it looks from the outside, from what's going on at the referring end, so they get the big picture of how the whole thing works. Mock drills has to be the best that we have found as far as training goes, especially in our telestroke program. But for our call center nurses and the distant site, practicing the protocols and actually going through scenarios as if it were a real stroke happening. We do just as many of these calls a month as we do live strokes. So that is what teaches not only the new employees, but also keeps everybody fresh on what they're to do. We've even had patients quote, "That went so smoothly. It's like you guys, had practiced it before." Well, very good, because we had many times. And then QA, as I had mentioned before, having them do self-review of their recordings is a great training tool. And then also the supervisor, the nurse supervisor, reviewing recordings and giving them feedback. So we noticed that, a big source of frustration was the nurses troubleshooting these interactive video issues that would happen. The more that we grew our programs, the more connections we were making, the more issues that, the more you do, the more issues you are going to find. So they were having to be clinical nurses, triage nurses, and now all of a sudden they're techies too. Well, some of them really were and adapted well to that and were good at it. Others weren't, and it's just not, just as if we looked at all of us in a room, even though we all do telemedicine, everybody doesn't have the same skill level as the next person. So this really caused a great deal of stress for some of them. Some of them really went into overload. So we had to look at, okay, what are we going to do? So what the changes that we made, the solutions that we brought in were, first of all, we got video support for the call center. Well, we had it already as far as we had our own video techs, but they were remote. They were outside the call center, and they were business hours. After business hours, they were on call only, and we're having to help figure things out from a distance. So we brought our own video conferencing techs into the call center 24/7. They were ours, and they were there to make the connections, monitor the call as it went on, and then if anything happened, they were there to figure out what the issues were. Then we separated our projects. You saw our list of projects that grew, and there's even more now. Some of those projects didn't need a nurse. Some of them were merely just connections and the call being monitored and counted, and they were our project and we wanted it to come through us, but it didn't really have a clinical piece for the nurse. So we separated those out, and we kept those that actually needed a nurse and needed to be clinical, like our telestroke program. We kept them for those, and then let our new video conferencing, now they're in the call center, have the other projects. And I'm going to try to hurry because we're out of time. And then just recently, well, and also backing up just a little bit, a couple years ago we got a new call center, and when we did get the new call center, we isolated our video conferencing area all to itself. So before, where it was part of the call center, it was happening, nurses with headsets on right next to another nurse that was triaging. We separated that out into its own area where doors could be closed. They didn't have to wear headsets unless there was other stuff going on, and where the video conferencing technicians were there in the same room with them. So that really improved things a lot. Our latest things that we have changed is we've looked at how can we extend the nurses, even further. We noticed that some of the projects didn't need a clinical person. Now, those that do need a clinical person, does it have to be a registered nurse? Well, our answer to that was no, it didn't necessarily, but it needed somebody that had critical thinking skills and that knew triage, paramedics. So over this last year, it was a concept, but really over the last 6 months, we've hired paramedics, or I call them telemedics. Isn't that cute? So I coined it. I need to get that, a little R next to that. But so we now have them 24/7. It's working very well. Our nurses are still involved in the projects because they help when we get a big, just like anything else. When strokes happen, it seems like we have 3 at a time, or bam, 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 all together, and then quiet time, just like any other clinical setting that you may know, feast or famine. So our nurses are still involved and help the paramedics and are still making the telemedicine, are still involved in that. We have a nurse supervisor that's over the telemedics too. And let me make sure, I'm sorry, I'm trying to rush here at the end, make sure we get everything. But that's it. I guess we're ready for questions.
Yeah. Thank you, Donna.